Xiaojing from New Zealand. The presentation is entitled The Effect of IDDSI Tailored Interventions on Staff Knowledge and Texture-Modified Diets Compliance in Aged Care. Sharon, are you ready?
Hi.
Okay, yes. The floor is yours.
Please play. Hi everyone, my name is Sharon. I'm a registered dietitian and I'm currently doing my PhD with Dr. Andrea Braakhuis and Dr. Anna Miles. My research focusing on the use of texture-modified diets. We conducted a series of projects on IDDSI implementation in New Zealand aged care facilities. And today we are looking at the effect of the tailored interventions we designed. And here I declare none of the authors have conflict of interest. So when we are preparing texture-modified diets, we need a guideline to follow to ensure patients received appropriate level of texture and consistency. There was lack of common standards for dysphagia management before the International Dysphagia Diet Standardisation Initiative. New Zealand adopted IDDSI in 2018. Prior to this, the majority of New Zealand healthcare settings used Australian standards. Although the major structure is the same, there are still several changes that need to be addressed. So in our study, we firstly designed a tailored intervention to all 5 participating facilities, using the barriers and facilitators we found in the previous project using the consolidated framework of implementation science. Then we aim to evaluate the effectiveness of these interventions on staff knowledge levels towards IDDSI and dysphagia and provision of texture-modified diets compliance. In our first observational study, we conducted several assessments to evaluate their IDDSI implementation progress in the care home, including texture-modified diet audits and staff surveys to test their baseline knowledge level and attitude towards IDDSI. We used the data analyzed from the previous study and the consolidated framework intervention matching tool to select the corresponding strategies overcoming the barriers. After the interventions were delivered, we conducted a sample day texture-modified audits again for all meals and levels using the IDDSI testing methods and audit tools. We also handed out post-surveys to clinical and kitchen staff to test their knowledge of IDDSI and dysphagia, also their opinions towards the interventions. We then compared the results between the pre- and post-surveys and audits. There were 4 main barriers we have identified. Most of the facility managers mentioned they didn't have a plan to deliver IDDSI systematically. Therefore, we had meetings with their manager teams, discussed the weakness and strengths we found from the evaluation, and detailed action plans to assist the implementation. Secondly, many staff weren't aware of the changes. The training they've done wasn't compulsory, so we found that lots of the staff weren't actively involved. Some facilities had reward system for staff performance, but none regarding dysphagia monitoring or food service. To overcome this, we developed an educational package for the staff and also conducted training workshops to provide hands-on food preparation and testing opportunities and knowledge sharing. Also, none of the facilities had an appointed champion from clinical or food service team to guide the implementation. This was covered in the manager meetings, and we identified and prepared champions from kitchens and caregivers who spent most of the time preparing and serving texture-modified food. Lastly, lack of performance measurement brought up to our attention, which may lead to the poor attention to enforce the needs of being compliant with IDDSI. Our team conducted audits and provided feedback. We also trained the kitchen manager to use the IDDSI testing methods and tools, and encouraged them to regularly monitor the texture-modified diets for quality assurance. After the team meetings, we delivered several tailored materials, education workshops, and monitoring tools for facilities as part of the intervention plan. We developed a recipe book covering all meal options for each levels, especially for breakfast and dessert, which the kitchen found to be the hardest to prepare. We also handed out food booklets, dysphagia knowledge flyers to the staff, and put up IDDSI posters in the nursing station and the kitchen. To refresh staff memories, we made IDDSI label stickers with color, number, and name to put on the resident meal cover. For those staff who weren't able to attend the workshop and future new staff, we encouraged them to watch the video training package. Several monitoring tools were introduced to the clinical and kitchen staff. 6 months after the intervention, we found the compliance of all 3 levels of texture-modified diets were significantly increased. Also, there were more food options provided to each level, in particular tea time options. 4 facilities changed to commercial packaged minced moist and pureed meals, where they were able to shape the meals, but they were still able to make their own breakfast and desserts. Staff were more aware of the minced moist and softer bite-sized meal requirements. However, the compliance of soft and bite-sized was still lower than the others, mostly due to the food wasn't chopped into the required size. Looking at staff knowledge, there were significantly more staff learned about IDDSI, and the overall score in Dysphagia questions and IDDSI sections both showed significant improvement comparing to pre-survey. For better validity, in both surveys, questions covered the same topics but were asked differently. More staff were able to answer the dysphagia symptoms, complications, and feeding positions correctly. As well, more staff knew about IDDSI descriptors, testing tools, and were able to select the suitable food for the texture-modified diet. Knowledge regarding testing methods still need to be addressed. 63% of the staff completed the post-surveys reported they attended an education workshop. A significantly higher percentage of the staff considered they have received sufficient learning resources comparing to the 40% in pre-intervention. Also, we asked whether they've seen changes in the provision of texture-modified diets. 82% staff reported seeing positive improvements. We asked the staff what type of resources they have received in the last 6 months. Attending the workshop and posters were received the most. Using recommended online learning access was the least common resources. In conclusion, the IDDSI tailored interventions showed positive improvement in both texture-modified diet provision and staff knowledge, which facilitate the IDDSI implementation. Healthcare professionals should be highly involved in the implementation process, especially dietitians and speech-language therapists who can assist with assessment, planning, and education training. Successful implementation of IDDSI allows improvement of quality of care and patient safety. Our study only tested the effectiveness of the intervention in 6 months. Future studies should consider testing the longer time period for evaluating sustainability. Thank you for your time, and I would like to acknowledge my supervisors Anna and Andrea for their continuous support.
Thank you very much for the great presentation and beautiful slides. So, you did a great job. So, I wonder if I could ask a question. I think you reported the result of the 2 studies. One was the study to identify barriers in introducing IDDSI-defined texture-modified diets in aged care facilities. And the other was to investigate the effect of the education on implementation of the texture-modified diet. The barriers you identified are very important if we want to educate staff and introduce IDDSI-defined texture-modified diet in our settings. Regarding this, I often hear the introduction of new cooking methods meet with strong objections from the staff in Japan. It's commonly due to increasing cost and underhanded manpower. Could you tell the situation in New Zealand? Is it similar to Japan?
Yes. So in New Zealand, most of the facility, they already prepared pureed diet for all the residents, but the soft and bite-sized and minced and moist was less common. And from the facilities that I investigated, some of them, they started using the commercial prepackaged ones for minced and moist and pureed. And most of the feedback I got from the managers are, yes, it is a little bit more expensive in the expense to purchase, but it saves a lot of manpower in the kitchen to prepare it.
Is it covered health insurance? Cooking modified diet.
You mean the purchase of the commercial ones?
Yeah.
So I think it's covered within their budget for each resident. Yeah, so it's usually the manager, they would calculate how much expense they have for each resident per day, and apparently it's within their budget. It's a little bit pushing in the first few months, but after they got around, because they also found how to use the leftover ones that they couldn't finish in the whole tub. So sometimes they will make a soup from it for all the other residents as well. And also they mentioned because those commercial ones are fortified with extra protein. So it's also save some cost from giving them supplements. Yeah.
I see. We have a question. Professor Mori, I want to know. He think the time and effort of cooking is very important point. Did the cooking time for dysphagia diet shorten after the training?
So like I mentioned, 3 facilities changed into using the commercial ones. So it saved them time in cooking. But for those ones, they use sometimes to prepare it a day before because they also shape it. So they usually scoop it out, shape it, and then put it in the freezer and then heat it up the next day. But for those things, the kitchen assistant can do it. So it saves time from chef doing it. Usually they would have 1 or 2 chefs cooking meals and 2 or 3 kitchen assistants. So kitchen assistants are trained to do that, and they do think it's more time saving.
That's right. So your strategy to educate staff included online education system, video, handouts, workshops, and posters. So many.
Yeah.
The answer from the participants showed workshop and posters are very good and sufficient. What do you think is the most important and effective thing?
I think the workshop and posters are very well received because we display the poster in the nursing station and also some in the dining room just when they have a board. So it's to keep reminding them of the color and number of the whole IDDSI framework. And
the knowledge, yeah.
Yes, and so we also provide them some sticker labels that they can put on the mail. So all the healthcare assistants, they constantly seeing that as a reminder, and they are more aware of, oh, this is level 5. And this is the orange label. And everyone gives a really positive feedback in the hands-on practice in the workshop.
The approach keep the staff good knowledge, yeah?
Yeah, because they just need to be more involved in the training.
Sustainability, okay. So we're running short of time. Thank you, Sharon. Thank you very much. So let's move on to the final speaker. The final speaker of the session is Professor Tomoko Maehara. The title of her speech is Relationship Between Leisure Time Exercise and Dysphagia Risk in Japanese Population. So Tomoko, are you ready?
Yes. Thank you for your introduction.
So over to you.
Thank you. Thank you for your introduction. I'm Tomoko Maehara from Graduate School of Hiroshima University, Department of Oral Epidemiology. Please start the video.
Thank you for listening to my presentation. I'd like to talk about relationships between leisure time exercise and dysphagia risk in the Japanese population. We have no she or I. Introduction. Previous studies showed that dysphagia is related with age, depressive tendencies, medications, and chronic diseases. Dysphagia can lead to silent aspiration, pneumonia, or related with some diseases and reduced activity of daily living and generalized muscle weakness. Muscle weakness is related to lack of physical activity and can lead to dysphagia. Studies have been conducted on the relationships between dysphagia and physical activity or muscle weakness. However, few studies investigated in the community, and many studies focused on frailty or elderly people than the general adults. In addition, questionnaire is useful to screen community-dwelling individuals. Therefore, our study aimed to clarify the relationships between physical activity and dysphagia in community-dwelling adults using a questionnaire-based survey. Method. The data for this study obtained from the Japan Institutional Collaborative Cohort Study called the JMIC study. The JMIC study is a long-term cohort study in Japan. Participants are participated in the health checkup exam needs. We used the data of the Shizuoka study and the Daiko study. It was the second survey after 5 years from baseline survey, aged 39 to 76 years old participants. Participants who responded to a questionnaire on their dysphagia risk and did not have any missing values were included in the present analysis. This is an overview of questionnaire. The contents are as shown here. We used the questionnaire to qualify leisure time exercise. It was estimated on the basis of the International Physical Activity Questionnaire. The amount of total leisure time exercise was expressed as MET-hour per week for each of the three intensities. MET is a unit of exercise intensity and shows the energy as the activity level. The total amount was calculated by summing these values by applying this formula. Dysphagia risk was evaluated using the Dysphagia Risk Assessment for the Community-Dwelling Elderly Questionnaire called the DRIS. DRIS includes 12 items, and score from 0 to 2 is assigned to each item. Total score of DRIS ranges from 0 to 24. A score of 4 or more indicates risk of dysphagia. Statistical analysis is as shown here. Results. The mean age at the survey is shown here and indicating a significantly higher age in men. This graph shows the average DRIS score by age group. The value tended to increase significantly as the age increased. The prevalence of dysphagia was 23.8%, showing a significantly higher result for women. Table 1 shows the characteristics of the study participants according to the prevalence of dysphagia by sex. There were significant differences in these items drawn with red lines. Among men, there were differences in working time, educational level, and prevalence of cancer. Next is the amount of leisure time exercise. The group was divided into 4 groups. The odds ratio was calculated and the tendency was tested. As Table 2 indicates, greater leisure time exercise amount was associated with lower prevalence of dysphagia, and individuals in the highest leisure time exercise quartile had a considerably lower odds ratio, showing significant results independently. In addition, women also showed a low odds ratio while men was borderline significance after adjusting for depletion. Discussion. Among the community-dwelling adults, greater leisure time exercise was associated with a lower prevalence of dysphagia. We showed studies about physical activity and swallowing muscle. Experimental study with rats have shown that rats after running for 10 minutes for 8 weeks have increased tongue and breathing strength. A study in humans, there was an association between trunk muscle mass and swallowing muscle mass. Physical activity can maintain and improve muscle strength and prevent dysphagia. Next, the meds were calculated using a self-administered questionnaire, and in previous studies reported that amount of subjective physical activity evaluated by the questionnaire was similar to the value of objective physical activity. The amount of physical activity of this study was equivalent to the actual. Leisure time activities were associated with higher tongue pressure, suggesting that physical activity is a determinant of oral function. Women has higher prevalence of dysphagia in this study. Swallowing problems are considered to be subjective, and women are more aware of the problems related to chewing and swallowing. The prevalence of dysphagia in middle-aged is higher than average, so we need to focus on the middle-aged. Men are affected by mental health. Psychological approach is important for prevention and improvement of dysphagia. Limitation. This was a cross-sectional study, and we could not prove a causal relationship. The assessment of questionnaire has validity and reliability, but it is not an objective assessment or accurate diagnosis. The participants of this study are considered to be a health-conscious population living in the community. The population lived in a limited area in Japan, and the age of the participants was relatively young. Longitudinal studies needed to be conducted in the future. Conclusion. Our results suggest that more leisure time exercise is independently associated with a lower risk of dysphagia in the Japanese adults. Thank you for your attention.
Thank you very much, Tomoko, for the great presentation. So, anyone has a comment? Nothing? Okay, may I ask a question first? So, the leisure time activity was considered as the important element in your study.
Yes.
You used IPAC in estimating leisure time activity. Could you provide more information about IPAC? Is it easy to answer, or how much time did the participant need to answer IPAC?
Thank you for your question. The IPAQ is a questionnaire assessing population levels of physical activity across 12 countries, and it asked about physical activity throughout the day. Recalling an average week, it asked about exercise time by intensity and physical activity time like walking time and sitting time and so on. It's not only leisure time exercise, but also all physical activities. In our study, based on the IPAQ and previous studies in Japan, the participants asked to answer separately for daily physical activities such as work and housework, and for exercise during the leisure time. Since this survey is based on the short version, it would simply take about 5 minutes.
5 minutes.
To answer. However, since people's activities are not constant every day, we think that there are some difficulties in recalling a week's activities and answering the time for each exercise intensity.
Okay. We have a comment from Professor Kiyomiya. He wants to know about, he commented, I was a little surprised to see the significant difference in gender. Is it a difference in muscle mass since they are still young? It's due to the muscle mass?
Thank you for your question. I think it is related to muscle mass, but it is not, we don't have the data of muscle mass.
Mm-hmm.
So
okay.
I'm not sure.
Mm-hmm. It's difficult for the lots of people to estimate measure muscle mass.
Yeah.
Yeah. So, Professor Sakai want to know, were there any difference in social background, such as education, income, or smoking history between the groups?
Thank you for your question. I showed table 1 and educational. Yes, education level is different in men, but it's not different in women. And the smoking status is both of the men and the women is different. And income is not, I don't have the data of income.
Mm-hmm. Okay, thank you very much. So the final question, we have another question from Professor Nishioka. I know him. Were the leisure time and dysphagia risk corrected by the same interviewer, or were they assessed by the different interviewer?
This data were assessed by the same interviewers. Yes.
Mm-hmm. Okay, thank you very much. I want to know the difference between DRACE and E10. Screening dysphagia risk using questionnaire is very useful for community dwelling people. I think the E10 questionnaire is common as a screening tool for dysphagia risk. However, your study employed a DRACE questionnaire. I don't know much about DRACE. Could you provide more information about DRACE?
Yes, thank you for your question. The DRACE is a questionnaire made in Japan. The DRACE is a 12-item questionnaire on swallowing function that have been validated using objective measures such as tongue pressure. The feature is that it is a questionnaire made for the community dwelling people. It has 2 more items than the EAT10, but I think it's not difficult to answer. The EAT10 also asks about nutrition and QOL, such as weight loss, pleasure in eating or eating out, but it's not in the DRACE. In my opinion, the EAT10 is suitable for comprehensive assessment of life, and while the DRACE is more specific to swallowing function.
Swallowing function. Mm-hmm.
Yes.
Yeah, the EAT10 includes the outside eating.
Yeah.
Okay, thank you very much, Tomoko.
Thank you very much.
We expect you that the paper will be published.
Yes.
Already
yes.
published?
Yes, I'm writing.
Writing, okay.
Yes.
So, thank you very much. So today we had 4 speakers in this session. Now I have to say, this session is going to be closed. I thank all speakers and for the great contribution and the audience. Looking forward to seeing you face-to-face in the future conference. Thank you very much today.